I was just saying I have no conflicts of interest to declare. And the objectives are for all of you to recognize the increasing incidence of obesity in pregnancy, as well as some of the causes of that increase, and the association of obesity with other chronic diseases. Also to understand the potential for adverse maternal and fetal outcomes in the obese pregnancy. Understand the impact of hypertension and hypertensive disorders in pregnancy and the impact on perinatal outcome. And also to understand ways in which the healthcare provider can improve outcome in pregnancies that have these complications. So my first slide lists a whole list, and this is in no way comprehensive. Any chronic disease that can impact anyone can impact a pregnant woman. And the majority of them will have some adverse effects on pregnancy. I have chosen today to speak about obesity, hypertension, and diabetes. One, because the obese woman is more likely to have hypertension and diabetes, and they're all kind of interrelated. So that's why I picked those three topics to talk about. But trust me, all of these others that are listed do have adverse perinatal outcomes. And if you were here this morning talking about substance abuse, you'll see that addiction is also on the list. So, what is obesity? It is a chronic medical disease. We don't often think about it that way. For some of us, it's the elephant in the room. We don't want to talk about it. We don't want to deal with it. And I find this with my residents and students as well. It is extremely difficult to look at a woman and say, you are obese and therefore your baby's going to have this, that, and the other. So it is an important topic though, and I'll show you in a few slides how it's increasing in our nation and the impact that it's having on us. So there are all kinds of etiologies for obesity. Environmental, if you can't get decent food, if you can't get to the grocery store, if you have no sidewalks on which to walk and get some exercise, if you don't live near a park, if you're working 16 hours a day, all of these kinds of things are going to impact your risk for obesity. There are also genetic factors, physiologic and metabolic factors, behavioral and psychological reasons for it. And one of the things that I'm noticing in my practice is that I would say 50% or so of my patients are obese or morbidly obese, and so many of them suffer with depression. And so that psychological factor is really, really important. And it's hard to say, are they depressed because they're obese, or are they obese because they're depressed? And those answers we don't always have. Excuse me, in this country, we have about 127 million overweight people, and that number has increased since this slide was made, and 60 million obese. That is a lot of people who are at risk. And 9 million of those are severely obese. About 65% of Americans are affected by overweight and obesity. And it leads to more than 300,000 deaths annually, and that's probably an underestimation. And over $100 billion in healthcare costs. So when we talk about healthcare costs, this is really, really important. So how do we define obesity? I always encourage my residents to calculate the body mass index, which is the ratio of height to weight. And this gives you a number that you can look at, because just looking at people today does not tell you. Because we're so used to looking at people who are overweight and obese that we tend to not recognize it. So it is extremely important to calculate this number. So a normal weight person is 19.9 to 26 BMI. Underweight, of course, would be under 19.9. Overweight is 26.1 to 29.9. And anybody who is over 29.9 BMI is an obese individual. And I challenge each of you to just go online, Google BMI, and calculate your own BMI and see what you come up with. And it'll give you an idea also of what you can do as far as calculating your patients. You don't have to sit down with a calculator. There are lots of BMI calculators online. If you have Hippocrates, there's one in there, so it's pretty simple to do. And then you have class 1 obesity, which is up to 34.9, class 2, 35.9 to 39.9, and class 3, or morbid obesity, is when you're greater than or equal to a 40 BMI. And I have many individuals in my practice who are morbidly obese. So just to show you obesity trends in US adults, this is 1985. You'll see that the majority of states in the United States, there was no data. There really weren't many obese people. So nobody was really looking at it. It just was not of that much interest. You move on now to 1990, you'll see that more states are looking at it, and you're getting more states that have 10 to 14% obesity. 1995, about half the nation now is somewhere between 10 and 20% obesity. And then you look at 2005, and you have the majority of states with at least 20 to 24%, and a good number, 25 to 29% obese, and then a few states that are greater than 30% obese. Now, when you get to 2009, look at this. Look how many states now are greater than 30% obesity. So this is a growing trend, and it's one that we as a nation have to really examine and look at, because it impacts perinatal morbidity and mortality, but also personal morbidity and mortality and healthcare costs. So this is a very important issue. Then you look at state-specific prevalence and also by ethnicity. And earlier today we heard that there's great health disparity in adverse perinatal outcome. And this obesity issue in perinatal outcome, just like many other issues, is more prevalent in the Black non-Hispanic population. So it is another health disparity that we need to be concerned about. When you look at the trends in maternal obesity, they basically reflect obesity in the general population. So that more moms are obese today as well, and more are becoming obese. This is the big issue, one of the big issues. So it's exercise and diet. And everything is supersized. You know, I was commenting earlier that folks are up in arms about Mayor Bloomberg in New York making the drinks limit at 16 ounces. But I think we have to do something, because people are not doing it on their own. They are eating as much as you present them with, they will eat. And so we really have to get a handle on this and let people know that obesity is not the norm. This is not how you want to be because of the health consequences. So this is just a slide showing the optimal weight gain in pregnancy. These are the new recommendations. So if you're underweight, you can gain as much as 40 pounds. The normal patient shouldn't gain more than 35. Overweight, you should gain less. If you're obese, even less. So, and morbidly obese, I try to keep my patients at about a 10-pound weight gain. And this will not impact, the baby still grows. Baby's going to take what it needs. If mom is eating a nutritious diet, the baby will get what it needs. And the thing that you have to understand is that even if a woman loses weight in pregnancy, well, if you're eating 5,000 calories a day and you move down to 2,500, you are going to lose weight. But it's okay, because you're still eating, the baby's still going to get nourishment. And then, of course, if you have a twin or other multiple gestation, you want to gain more. One of the issues with weight gain in pregnancy is that it's one of the biggest contributors to obesity. So what actually happens is a woman has a baby, she gains 25, 30 pounds, she doesn't lose it. She has another baby, she does the same thing, she doesn't lose it, and so forth and so on. And so at the end of the day, these women wind up being more obese because they gain too much weight in pregnancy and they don't lose it. So as healthcare providers, it's important for us to recognize this and counsel women accordingly. Other issues are infertility. So we talk about perinatal mortality. None of us want to see a woman's baby die or be born prematurely. But what about the woman who can't get pregnant? And a lot of women who are obese and can't get pregnant do not really understand that their obesity could be the root cause for their infertility. So it's something else that impacts our reproductive abilities. What kinds of complications do these women have? Well, chronic hypertension, diabetes, They're more risk for getting pulmonary emboli and deep vein thrombosis, renal insufficiency because of hypertensive disorders and diabetes. They have strokes. They're more prone to have cancers, obstructive sleep apnea, and they also get arthritis. So there are a lot of complications that happen with these patients that we need to be aware of. Pregnancy-associated complications, when you look at things like pregnancy-induced hypertension or preeclampsia, thromboembolic disease, again, winding up needing to have your labor induced, either because you're post-dates, because obese women tend to carry their pregnancies longer, or because you have a complication like preeclampsia or growth restriction of your baby that caused you to be delivered early. You're also at higher risk to have a C-section and higher risk for wound infection. And when an obese woman has a C-section, the risk of complications from anesthesia, infection, hemorrhage are multiplied because of that obese state. When you look at severe obesity, I'll just go back, you see the odds ratios here range from at about 2 times the risk of other individuals. When you get to morbid obesity, that increases even higher. So all of these things are increased, and I do make my patients aware of this. They don't like me very much, but I do make them aware because I think that it's only fair that if you're taking care of a patient and she has risks, she needs to understand what they are. Even if it makes her angry, at least if something goes wrong, you can say, well, we did discuss this. Yeah. So again, more complications. If you look at gestational diabetes in the obese patient, very significant increase in the risk. Hypertension, preeclampsia. Now the other one is fetal macrosomia, or big babies. So when you talk about a big baby, what does that mean? Well, at the very least, it means mom may need a C-section. At the very worst, it may mean that she goes on to labor, she delivers her baby, the baby gets stuck in the birth canal, and the baby can have paralysis, the baby can have brain damage, the baby can die. So this is one obstetric emergency. All you have to do is say shoulder dystocia to an obstetrician, they go into a panic. It is a terrible situation. So this is not what we want for our babies. Now these women have less risk of growth restriction because they're more likely to have a heavier baby. So whatever growth restriction they might have because of hypertension is overweighed by the fact that they have heavier babies. And as you can see, cesarean delivery is also more frequent. Now, what is preeclampsia? I said that preeclampsia is more frequent. It is a condition that only happens in pregnancy. Some people call it toxemia, so you may have heard that word as well. It's a multi-system disorder. It affects every organ system of the mother. And importantly, it affects the uterus and the baby, very much so. So it is an important condition. It manifests itself by high blood pressure, protein in the urine. Women can even go on to develop renal failure or kidney failure. Eclampsia, which is manifest as maternal seizures. The baby can have growth problems because of this. The placenta, abruptio placenta, is when the placenta completely separates from the womb before the baby is born. And you can imagine that this can contribute to either the baby being injured or brain injured or dead. And also the mother can hemorrhage and suffer severe injury or death as well. HELLP syndrome is another condition where the woman can become anemic, platelets which help the blood to clot can decrease, and it also contributes significantly to mom and baby having adverse outcomes. So preeclampsia definitely is a significant contributor to fetal and maternal morbidity and mortality. And this condition is increased in women who are obese. Again, this is just another slide showing that the more obese you are, the worse the risk. Why does it happen? We really don't know why obese women have a higher risk for a lot of the things that I'm going to tell you. We don't know why, because we're just finding out that the risk is there. But there are cardiovascular risks with obesity. There's insulin resistance and inflammatory condition, and increased in blood vessel tone that can decrease blood flow to the uterus and the other organs of the mom, and this is why this may happen in obesity. So how do we manage this? One, well, prevention would be the best thing. So this is where your preconception care comes in. We're letting women know, even if you're not an obstetrician, woman comes in for a well-woman visit, she needs to know from you that her weight is not normal, that these risks are there, and that she needs to lose weight, and offer her nutritional counseling, etc., to try and help with that situation. We also, during the pregnancy, we're going to monitor the baby's growth to make sure it's going okay. We're going to do antenatal testing, non-stress testing, and biophysical profile on the baby to make sure that the baby's okay during this pregnancy. And we're going to give magnesium sulfate, which is what we use to prevent seizures in preeclampsia. And it's also helpful if we have to deliver early because of the preeclampsia to help protect the baby's brain. And we give antihypertensive medications and proceed with delivery. Other complications, gestational diabetes. So I mentioned to you initially that obesity, diabetes, and hypertension are linked. So the heavier a woman is, the more likely she is to get gestational diabetes. And that's related to increased insulin resistance, which all pregnant women have. But if you're obese, you're more likely to have even more. And as you can see, it's really increased in obese gravidas, and that there is a positive correlation with increased maternal weight. Now, the other thing you need to understand is that in outpatient populations, many of them don't have health care. Hopefully that's going to change soon, but they don't. So they don't go to the doctor. They may have diabetes and not know it. So even when we say, well, we're diagnosing this in pregnancy, it may actually be pregestational diabetes, which is even more dangerous than gestational diabetes. So it's important to keep that in mind. The other thing is that a woman who has gestational diabetes has a significantly increased risk of having overt diabetes in their lifetime. And this often happens within a year or two of the pregnancy that they had gestational diabetes in. So it's very important to let a woman know she has this risk and that she needs to be tested. I do go through with these women all of the risks of diabetes and why it's important to be tested to see if she has diabetes. There's also increased fetal morbidity. Once again, the baby can be big. So if you're already at risk for having a big baby because you're obese, and then you add gestational diabetes on top of that, you can imagine how large the baby can actually get. There's also an increased risk of shoulder dystocia, again, and brain injury and death. And neonatal complications, meaning that the baby may have to stay in the intensive care unit or hospital much longer than if the mom did not have gestational diabetes. So all of that, again, adds to complications for the baby and also adds to healthcare costs. But these children are also at risk for childhood obesity and diabetes. This is not what we want our children to have. So that risk that they incur in the womb continues to follow them throughout their lifetime. So it is a very important risk. This is just a picture that I found on the internet of a macrosomic baby. I'm not sure what the exact weight is, but I'd venture to say about 16, 17 pounds. This is a huge baby. And so you can imagine that this baby is starting off with a health problem.
Yes.
Absolutely. And you can also understand why this baby, if it attempted to come through the birth canal, I would venture to say this baby was delivered by cesarean. But you can imagine the injury that this baby would be subject to otherwise. And the other thing that happens with these babies is because they've been getting all this sugar from the mom throughout pregnancy, once we clamp the cord and there's no more sugar, the baby has in utero been cranking up the insulin to use that sugar. So once we clamp the umbilical cord, the baby's blood sugar plummets. And so this is another bad problem for the baby that keeps the baby in the hospital. There are other ones also, and I'll mention them a little further along. sure about my time. So, management. We, again, discuss the risks with the patient just to understand. We usually, if a patient is obese and has a family history of diabetes, we screen them early for diabetes, and if that's normal, we repeat it later. If they have diabetes, we want to make sure their blood sugars are under control. We want to look at the baby for weight and anatomy with ultrasound, understanding that women who are obese, it's very hard for us to see the baby. So it makes it much more difficult to deliver good prenatal care. Again, we're going to monitor the baby to try and make sure the baby's okay, and monitor for preeclampsia because that risk is there. And then we want to make a delivery plan with the mom. Now, you've heard we don't want to be delivering babies before 39 weeks. So we always plan, in general, because there's some risk of stillbirth in these babies, and I'll get to that a little further along also. We usually plan, in my practice, that when they're 39 weeks, we're going to get them delivered. If, however, they have complications that increase the risk, say the baby's too small or the baby's in distress, we may deliver earlier than that. So that's a reason for premature birth that we can't help, but it also leads to perinatal morbidity and mortality. I mentioned already that they have an increase in prolonged pregnancy. There's also an increased risk of multiple gestation in women who are obese, and urinary tract infections. And importantly, urinary tract infections contribute to the increased risk of premature birth. So this is something we don't want either. So if you have a woman who's obese, you should be screening her for urinary tract infection. The other important thing that we've found out in recent years is that these women are at increased risk of birth defects. This is something we did not know before. Neural tube defects or spina bifida is 2 times increased. Cardiac defects are increased, especially in African American women. Once again, another health disparity. Ventral wall defects or defects in the abdominal wall are more increased, and also clefts in the face and the mouth. So these are important issues. We don't know why this happens. It may be because of folate metabolism. We do know that folate is involved with neural tube defects, but for obese women specifically, we don't know why they have this increased risk. And it's important to understand that this risk is independent of all other risks, social, dietary, medical history. If you're obese and you're very healthy, you have a good social situation, everything is great, you still have an increased risk of a birth defect. And because of the obesity, as I mentioned earlier, it's hard for us to see the baby on ultrasound. So there may be a birth defect there that we cannot detect because we can't see the baby. With ultrasound, it's a sound wave that goes through the mom to the baby. And if there's a lot of mom, we just can't get through to the baby. So we also explain to moms this issue as well, because they may have the baby and say, well, doctor, you did 5 ultrasounds. Why didn't you see this birth defect? So we tell them that before the fact. This is just another slide summarizing the birth defects that you can see in women who are obese. And you do have this in your packet, so I'll let you take a look at that when you get your slides, because I don't want to run over, because I'll get yelled at, especially since we started late. So I've already mentioned this as well. It's a little easier for us to see on ultrasound how much the baby weighs because we're measuring bones, and those are a little easier to see on ultrasound. So I've already mentioned this as far as macrosomia and both birth injury and childhood obesity, etc. And the other thing is unexplained stillbirth. Obese women have a higher risk of stillbirth than non-obese women. So if you look at this particular, these studies looked at it, and if you're a lean or I guess normal weight person, your risk is 37 per 1,000. So it's about 3% risk in the population or so for it. But if you look at an obese woman, her risk is 121 per 1,000. That's quite a significant increase in the risk of stillbirth. So it presents a dilemma for us who are taking care of the patient, because if she were diabetic and had this risk, we would be monitoring her baby for the last part of pregnancy. However, we have such a large obese population now that if we actually did do fetal monitoring for every single obese woman, we wouldn't be able to handle it. So this is another problem. However, if a woman's obese and she has gestational diabetes or diabetes and hypertension or some other complications, then we do go ahead and monitor her. But it would not, we just wouldn't be able to handle every single woman. But they still have this risk of stillbirth. So this is another study that looked at this, and I just show you this one to show that as the pregnancy increases, the risk of stillbirth increases. So by the time you get to 37 to 39 weeks, the risk is 3.5 times that of the normal population. So it's a dilemma, because if we deliver early, there are risks to the baby, and if we wait, there are risks to the baby too in this population. This is just another slide showing the health disparity that if you're black, you're more likely to be obese, and if you're obese, you're more likely to have stillbirth. Increased risk of C-section, I've already mentioned that. But even if you don't have a medical reason for a C-section, your labor may not be as good if you're obese, so you may want to have a C-section. And that's not good for mom at all. The C-section risks are increased also when you're obese, because it's a longer, tougher surgery. It's harder to get in and get the baby out, and it's harder to get mom closed up again. And then after she has the baby, she has increased risk of wound infection, infection altogether in the uterus, and wound separation. All of these things are distressful to a mom. I mean, nobody wants to be walking around with an open wound. And also healthcare dollars to get the healthcare that you need to get it closed again. So as far as managing these women, I counsel them about the risk of all these things: miscarriage, multiple gestation, hypertensive disorders, diabetes, anomalies in fetal death. And you can imagine, sitting there telling a woman this, she's looking at me like, what are you talking about? Because they're just not aware. And actually, many healthcare providers are not aware either. So I do counsel them about this. In the second trimester, I'm going to do my best to see that baby on ultrasound to see if there's anything wrong. We want to do follow-up ultrasounds for growth. Usually we feel the baby. We do what's called Leopold's maneuvers to see how big it is. And we measure the fundal height, or the height of the uterus. In a woman who has, 10 centimeters of extra adipose tissue, you can't feel the baby. And you can't measure the fundus very well. So ultrasound is a tool that will help you, because just like these babies can be big, because of the other complications these women have, the baby can also be small. And you want to know that before the fact. And I have several women in my practice right now who are obese and have very growth-restricted fetuses. Again, we're going to continue to monitor for adverse health outcomes, continue ultrasound. Now we're going to start non-stress testing for the baby to make sure the baby's okay. Nutritional counseling, this should go on throughout pregnancy in these women, and a delivery plan. So if the woman's obese and she has no complications, there's really no reason to intervene. If there are complications, then such as hypertension and diabetes, I usually deliver at 39 weeks. Of course, if the complications are severe and occur earlier than that, I deliver earlier. Postpartum, very important. These women have all kinds of risk after they've delivered. We want to make sure that we get them moving around real quick. Very important to encourage breastfeeding. It's good for the baby and may help prevent childhood obesity. And also, it may help the woman to lose weight. Also, I'm not going to go into all the other benefits of breastfeeding. If you went to the breastfeeding symposium or you're familiar, you already know it's a very important issue. So I do encourage breastfeeding. And just because they're obese and they have large breasts doesn't mean they can't breastfeed. There are techniques to help them do that. I mentioned that many of these women are depressed, so it's very important to screen them for postpartum depression, which can be deadly if it becomes severe for both mom and baby. Family planning is important. Again, you don't want her getting pregnant again in 2 months because she's not going to lose the weight. That rolling ball is going to keep going. And also nutritional counseling. We don't have enough of this. We need more dietitians, RDs, to counsel these women. But in the absence of that, it should be our job to make sure they understand how to eat healthy and what they can do to try and lose weight. And I should mention that bariatric surgery is a plus for these women if they can get it, because their pregnancy outcomes are going to be much better if they've had the surgery and they lose weight. Now, I'm just going to move on to chronic hypertension. That is defined as a blood pressure in pregnancy of 140/90 or greater prior to 20 weeks of gestational age. So we need the early diagnosis, or we need to know before they got pregnant that they had chronic hypertension. It complicates 1 to 5% of all pregnancies, and there's significant maternal and fetal morbidity and sometimes mortality in women who have chronic hypertension. And I've already mentioned that if a woman's obese, she has a higher risk of chronic hypertension. And you should also understand this is another area of health disparity. African American women are much more likely than other women to have chronic hypertension. The other thing you should understand is that women are having babies later and later, you know this. And the older you are, the more likely you are to have hypertension. So it's important to look for this and encourage women to have a health checkup before they get pregnant, preconception care, which is a big part of the Affordable Care Act. We do need this. We need women visits so that when a woman is planning to get pregnant, she'll have some idea of what her risks are. And even if she's not planning to get pregnant, because 50% or more of pregnancies are unplanned, if she's had a healthcare visit, at least you'll have some idea of what her issues are before she conceives. You see here that the complications that can occur, preeclampsia occurs with women with mild hypertension in 14 to 28% of those women. And with severe hypertension, look at the number, preeclampsia 50 to 79%. So these women are at risk and they do need to be watched closely in pregnancy. And the same thing with abruptio placenta, which I spoke of before, where the placenta separates before the baby is born. The risk of that is significantly higher in women who are hypertensive as well. So we need to be monitoring these moms and babies extremely closely. Growth restriction, also a very important complication. These babies are very sick babies. So they're starting off in the womb not getting enough oxygen, not getting enough nourishment, because the placenta is not working right. The placenta doesn't develop properly, and the blood flow to the uterus is also impaired. So these babies start off in the womb in a kind of a starvation state, and they are at risk for death in the womb and all kinds of complications. So this is why if you can't tell with your examination how big or small the baby is, you need to do an ultrasound so you know what's going on. These babies also have a higher risk of bleeding into the brain and perinatal death. So this is another picture I found. This is a growth-restricted fetus. You can see how small this baby is. And this baby has been suffering and will continue to suffer because these babies are also at risk for obesity and hypertension in childhood and adulthood. How do we manage it? Well, some women may need blood pressure medications, and we do have some that are very safe, well studied in pregnancy, that we've been using for a long time, that they can take in pregnancy to keep their blood pressure within a reasonable range. You want to monitor their blood pressure and their fetal growth. You want to check out their kidney function when they first come to your office, because hypertension can lead to kidney disease, which can also cause problems in pregnancy. Again, monitor the baby very closely and plan for delivery. So if I have a woman who's obese and diabetic and hypertensive, I'm going to be just on top of her like white on rice, watching her every step of the way and planning for her delivery. And the plan is a dual plan. It's not me just telling her what needs to happen, but discussing with her what the problems are and why she needs to be delivered early, because some women say, I don't want to be delivered early, or I don't want a C-section. So you really have to sit down and talk with the patient. So now we'll move on to pregestational diabetes. This is diabetes that has been diagnosed prior to pregnancy, and that can be type 1 diabetes, which is diagnosed early in life, or type 2. There wasn't enough time to really go through in detail, but the complications for pregnancy are about the same in both of these conditions. So mom is usually on some type of medication, either pills or insulin, to control her blood sugar. And this makes her at risk for either not having enough of the medication to keep her blood sugar within normal range, it's too high, or the blood sugar can be too low. And both of these conditions are dangerous for the fetus. If the blood sugar is too high, there's a higher risk of birth defects and fetal macrosomia. If the blood sugar is too low, the fetus can actually suffer brain damage. So we have to monitor them very carefully. They're at higher risk for preeclampsia, and you see preeclampsia comes up a lot. It's a very important complication in pregnancy. Diabetes can affect all of the organ systems of the mom, so she's at risk. You start from the head to the toe, stroke, blindness, so we have to check her eyes frequently in pregnancy, because when we bring her blood sugar under control, paradoxically, her eye conditions may get worse. So she should have her eyes looked at in every trimester of pregnancy. Her kidney function may deteriorate, so we have to watch that carefully. She may have coronary artery disease, and this is particularly true if she's obese as well. So we have to be concerned about that. She may also have some risk for heart failure, so we have to watch out for that. And of course, she's at higher risk for cesarean delivery because of all the things that I've just said to you. So the fetal risks, macrosomia 40%. So that's a huge number. And if the diabetes is poorly controlled, what you will get is that baby I just showed you. The baby just grows and grows and grows. And anomalies, birth defects, very big complication in diabetic women, particularly when their blood sugar is poorly controlled in the first trimester. When the baby's being formed, they can have an increased risk of birth defects. Fetal demise, blood sugar can be controlled or poorly controlled. These women are still at risk for stillbirth. So we have to watch them very, very carefully. Of course, having the blood sugar under control will decrease this risk significantly. And then what we call iatrogenic prematurity, which means mommy's sick or baby's sick, so we've got to deliver. So that's another issue, and these babies can spend a lot of time in the NICU. Babies can have respiratory distress syndrome. When moms have pregestational diabetes, the baby's lungs do not mature in the normal fashion. So even if the baby is born close to term, that baby's lungs may not be functioning, and they may have to spend a lot of time in the intensive care unit on a ventilator. These babies have all kinds of blood problems, low blood sugar, hyperbilirubinemia or jaundice. I don't know if you've seen the babies under what we call the Billy light. These babies are at higher risk. And they can have other electrolyte imbalances as well. These babies can have cardiomyopathy, which means the heart muscle has been damaged by the mother's diabetes. And this is also very bad for the baby. And then, again, the risks of childhood obesity and diabetes and the metabolic syndrome. So these babies really are at risk. So how do we manage them? Again, preconception care is vital. The best scenario for mom who has diabetes is for her to see her doctor, get her blood sugars under control, and then get pregnant. Because usually by the time the woman gets to you at 10 to 12 weeks, the damage to the baby's organs have already been done. So you want to have that blood sugar under control before she conceives. So I always tell my residents, no matter what specialty you're in, if you're an ophthalmologist, you know, if you're an orthopedist, whoever you are, if you have a patient that's diabetic and of childbearing age, just give them the hint that they, if they're thinking about pregnancy, they should get their blood sugars under control. It's very important. I told you that mom's organs can have had a lot of damage for diabetes. So we do go through a long workup with the moms to see if there are other organs that are damaged, so that we can look at that and see what impact it might have on the pregnancy. It may call for team management. Say if she has renal problems, the kidneys aren't working well, I may have to work with a kidney physician to manage her pregnancy because of that issue. So team management is very important. And then when you look at the baby, if the diabetic mom's baby has a birth defect, then we need to get the neonatologist involved, we need to get the pediatric surgeon involved, maternal fetal medicine involved, whoever, to make sure that the outcome, we optimize the outcome of this pregnancy. We don't want to be in a little hospital with no services and have a baby born with a bad heart defect that we can't deal with and not know that it's happening. So, but again, if the mom's obese, it still makes it difficult for us to know. And monitor fetal growth. I think I've said all of these things already several times about how we have to plan, monitor. So in summary, obesity, hypertension, and diabetes are associated with significant adverse pregnancy outcomes. They contribute to long-term negative health effects for both the mother and the child. And we can improve that with proper management. That means preconception, interconception, and post-delivery care. So it is extremely important that we counsel the mom and that she understands that all of this is really important for her health and the health of her baby. And preconception counseling and therapy are extremely important to decrease pregnancy-associated risks in women who have these complications. So with that, I'll end, and if you have any questions, I'll be glad to answer them.